The visual nature of it means that you know, picture paints 1,000 words, doesn't it? And so the map of medicine's picture paints 1,000 words of description around what's going to happen to you as you go through a pathway.
It will cut down the journey or that the patient takes from referral to treatment because they will be hopefully assessed more appropriately. Hopefully they would be referred to the appropriate consultant of the musculoskeletal team, and hopefully patients would appreciate their condition a lot more even prior to referral, because all that information is already in the map of medicine framework, which will be accessible to our GPs. So in that condition, a robust referral mechanism will help referral to treatment time.
For the AMD pathway, we reduced the waiting times from about 20 weeks to 2 weeks because we were able to develop a pathway so our local health service provider could provide the services, where in the past the patients were all sent into one hospital which was quite a way away. So we've actually opened, by using the pathways, we've actually opened up the capacity for that whole area of the country.
The pathway locally has been viewed by lots of consultants, lots of nurses, lots of others. So it's getting good profile, and people are using it in terms of informing, looking at the pathway around the tumour site, looking at the journeys with patients.
I think the most important issue is communication, because for years and years our GP colleagues do not exactly know what we want from them before referring a patient. That is a very important understanding of the communication process that Map of Medicine has initiated.
I think there's a lot around education, around skilling up, because you're not only learning how to use pathways, but you're learning about service redesign and how it's easier to work with clinicians when you have that basic understanding of what it is that drives them to provide better services.
Map of Medicine starts life as an educational resource, as an academic tool, as a place of interest for maybe nurses that are learning, for junior doctors, or maybe for consultants even who aren't particularly familiar with a particular area. They can go in, they can look at one of the 380 or so pathways, they can find information behind those pathways, maybe look at some explicit informations and get some options.
It is an educational tool in which it clearly takes the doctor through a patient's condition to the point of treatment, giving various options of treatment, and all these are well structured texts, are well referenced. At the same time, the whole pathway has got procedure which has got images and videos. Therefore, it will help as an educational tool.
I think it's invaluable with regards to service improvement. As I said, it's a real good starting tool. We can see we've got some sort of drafts of where we are now and where we need to be. So I find it a very useful tool. It's also a really good visual tool, and it gets clinicians involved in the process.
Right from the chief executive level to our business manager, they are very interested to find out how this is progressing, because it will in the long term help in creating a bridge between the two.
I think it's about certainty around the best practice and best processes. It's around being clear what the benefits are for patients. It's also very clear on the what are called the access points, who is to do what, where and when, and what is to being clear about what is appropriately done in primary care and what is best done in secondary care. So you're actually using the best parts of the whole health economy for the benefits of patients.
The whole Map of Medicine is a dynamic process where we have put in as clinicians guidelines and protocols, assessment tools, which we have provided, or rather we could probably help our primary care physicians to gather and all that information before they're referred to the secondary care. And I think that's a useful tool which our managers are quite happy with in terms of reducing the waiting time targets.
For me, it's about evidence and providing good practice. So we've got the library staff involved, and we can use the national service frameworks, any good practice guides or evidence and research that's out there at the moment, and make sure we bring that into the pathway, make sure that what we're changing, we can't just change pathways willy-nilly, we need to make sure that they're following good practice. And the map of medicine just gives you the structure to do that. Well, I think from a commissioning perspective, the useful part of it is we can look at what can we deliver in primary care, what should be coming into secondary care, and we can actually change around the way we deliver our services. And also adding the timelines to the map. That gives us great incentives to move things into different areas and to look at, good example with the carpal tunnel pathway, we've moved nerve conduction into primary care. So although we actually deliver the service in the hospital, they don't come and see the consultant until all the workup's been complete. So using the map of medicine just highlights what needs to be done and how can we deliver it differently.
So one of the things that's happened with our breast pathway is that it's timed. So cancer, for clinical reasons as well as operational or quality standard reasons, is a timed pathway. That can be done on all pathways. That can inform clinicians and managers when they're looking at it, and indeed commissioners, as to, well, how long do these things take? And indeed, if you have localisation, maybe between health communities or between organisations, actually commissioners can actually have a look to see whether the time pathway at one place is better than the time pathway at another, or maybe that actually the flow of the pathway in terms of where services are delivered is better for patients in their community than it is perhaps for patients in another community.
The clinicians are actually telling us how they want pathways to be run, what is the most appropriate pathways, and we can then attach the pathways onto the contracts and say, you know, these are the things that we do not want you to do, but these are the things we do want you to do. These are the services we want.
The gap between what we know and what we do yawns like the Grand Canyon. Now, knowledge alone does not bridge the Grand Canyon, but having a way which we can write down in a form that people can understand what it is we want dramatically helps us achieve. If, for example, you ask, what does the NHS want for rheumatoid arthritis? I cannot show you any document other than the map of medicine. We have to write down what we want, and then there's half a chance that people will do it.